Righty, we are recording now, so I think we can go ahead and get started if you'd like to kick us off, Abby.
Sure. Welcome, everyone. Good evening, and welcome to the Implementation Science and Community Partnership series. This series is really a series that we started to create a space for sharing on implementation science and shared learning on implementation science as well. We have a mix of attendees that are from community partners who are not researchers to clearly some government participants and representatives as well who are interested in implementation science. And our hope is that through these discussions, we will be both talking through some frameworks and concepts, as well as having discussions related to a specific case where we have a researcher sharing how they have utilized implementation science in their existing work. And then we could have a rich discussion where we get to ask in-depth questions that many of us who are practicing in the field right now don't have the opportunity to because we're not in school anymore. So we look at this series as a great opportunity for discussion and learning. So today it is my honor to welcome our speakers. I'll give great thanks to Julie Pulerwitz as well as Christopher Kemp for sharing their expertise with us. I will start by introducing Christopher, who will be our opening speaker. So Christopher Kemp is faculty with the Center for Indigenous Health and Center for AIDS Research Implementation Science Core at the Johns Hopkins Bloomberg School of Public Health. He's an implementation scientist dedicated to supporting health systems and communities to deliver services that community members need and want. Christopher has a particular focus on preventative and treatment services related to mental health, HIV, and nutrition. He holds an MPH and PhD from the University of Washington School of Public Health. So welcome, Christopher. We'll have you open. And then after Christopher presents, we'll open it up for some questions. And then we'll turn to Julie. And Julie is a senior socio-behavioral scientist at the Population Council, providing leadership for a global portfolio of research focused on HIV, violence, gender inequalities, and stigma, as well as faculty at George Washington University, where she teaches a class on implementation science. Dr. Pulerwitz is part of the scientific leadership team of the HIV Prevention Trials Network, HPTN, and is co-chair of USAID's Male Engagement Task Force, and is co-chair of the Global Scientific Interest Group at the DC Center for AIDS Research. She received her master's and doctoral degrees from the Harvard T. Chan School of Public Health and has worked in over 20 countries across Africa, Asia, and the Americas. So we will, like I said, start with Christopher. We'll have a good amount of questions in case you need to clear up any details related to models or frameworks related to implementation science. And then after Julie presents, we'll have questions specific to both presenters as well. So with that, welcome, Christopher, and let me know if you need any help sharing your slides.
Thank you, Abby. It's a pleasure to be here. Can you see my screen okay?
Yes,
All
we
right, so
can.
just to frame this presentation, I'm sort of stepping in for Dr. Laura Barris, who's a friend and colleague of mine from Hopkins, who I think had a conflict and asked if I'd be interested to present. And she said that this is really an opportunity to provide like a sort of mini lecture in a way, or educational session on theories, models, and frameworks for implementation science. And I already present on this for our course series at Hopkins on implementation science, so I thought it was a nice fit. But anyway, I like to keep this casual. If at any time you want to stop for questions, let me know. I'm going to kind of move quickly to make sure that there's plenty of time for Dr. Pulerwitz's lecture or talk. So yeah, if I'm moving too quickly, just let me know, and I can always stop for questions. In terms of an outline, what I'm going to do first is describe in my own mental model for how I feel implementation science works. And then I'll introduce, and I'm going to talk about the distinctions between the different types of theories, models, and frameworks that are commonly applied. And then I'll talk about how we use them to guide process and translation of research into practice, identification of contextual determinants, choosing strategies, and then evaluating implementation. And throughout, I'll make reference back just to keep grounding, these theories and this work in the real world. I'll refer back to a real world health example. And so for this, the illustrative gap that I'm going to use is the gap between the evidence around what works to reduce the risk of opioid use disorder and mortality, and what the reality of service delivery right now. So we all know, there are far too many deaths from overdose in the U.S. Medicines for opioid use disorder can dramatically reduce the risk of that death. Those medicines, including buprenorphine, are evidence-based and cost-effective, and most people with opioid use disorder don't receive treatment. So that's just going to be the framing example that I'll keep coming back to. All right, so I'm going to start by introducing my high-level conceptual model for implementation science. So I like to think of this field in terms of three really broad activities. They're all based around a strong assumption, which is that there exists some effective intervention or practice that could improve population health, but that for some reason is not being implemented well. Maybe it's not reaching the right people, maybe the quality is low. So the first core activity is identifying the contextual determinants of implementation success. And this is really asking the question, why is implementation of this intervention successful in some places and not in others? The second, to choose implementation strategies. This is saying, what can we do about that variation in implementation success? And finally, measuring implementation outcomes and other outcomes. So how do our strategies to improve implementation, how do they affect implementation, and how do they affect population health? And then lastly, I argue that all of the science has an inherent focus on equity, on ensuring that implementation is successful in lower resourced health systems or communities, that implementation strategies can improve equitable access to health services, and that these changes in equity are appropriately measured. So implementation in the real world is messy, it's complicated, and to make sense of that complexity, we rely heavily on distinct theoretical models and conceptual frameworks at each stage of this scientific practice. So we use theory to define context and delineate the contextual characteristics that either promote or inhibit implementation. We use theory to guide that process of translating knowledge into practice and implementing. We use our theories of contextual determinants to help us choose strategies to improve implementation. We've also used theory to collect those strategies into discrete taxonomies. And finally, we use theory to define the scope of our evaluation, define the outcomes of interest for our field. As defined by Per-Nilsson in this kind of seminal paper in this field, there are three broad types of theories, models, and frameworks in implementation science. So the first, process models, they describe the process of implementation and translating research into practice. They include things like the knowledge to action framework, quality implementation framework. The second type, the determinants and the implementation theories, these are the things that really help us understand what is context, and how do you describe the contextual factors that influence implementation effectiveness. So these include gigantic meta theories that you will have heard of before, like the consolidated framework for implementation research, as well as more detailed in-depth models like the theory of planned behavior or the theory of organizational readiness. And finally, the third type, as defined by Per-Nilsson, are the evaluation frameworks, which guide our thinking around outcome choice and outcome scope. So these are things like re-aim, precede, proceed, and the implementation outcomes framework. So it's important to note, as you're thinking about these, and often one thing we see among folks who are trying to use these for the first time is that they'll try to use them in isolation, but they're almost never applied in isolation. Each serve a distinct purpose in the science of implementation, and they're almost always integrated together in many different ways. So here, another visual representation of the implementation science field. On the left, defining context, choosing and testing your implementation strategies, and then measuring your implementation outcomes on the right. The process models, they really fit here. They say, how do we guide implementation and knowledge transfer? Process is generally thought of as a level of contextual analysis. So the process models are focused on this one level of analysis within the contextual bucket. The determinants and implementation theories are used to more broadly specify contextual constructs and support assessment of the contextual determinants, including the assessment of process. These same theories are then used to help choose implementation strategies and target specific contextual determinants, or strategies that target specific contextual determinants. And then the evaluative frameworks, they define the relevant outcomes and the scope of inquiry for the implementation study. So within your same research project, you'll probably use theories of process, context, and evaluation independently to serve different purposes. Okay, so just diving quickly into the process, some of the process models. The implementation process starts when a site is first exploring the possibility of adopting a new evidence-based practice. In an ideal world, they develop a strategic plan, they put in place the activities necessary to successfully implement the practice. This process has distinct phases. There's pre-implementation, implementation, and sustainment, and we use these frameworks or models to help guide and understand the process over these stages. Because implementation is so complex, the process models are particularly helpful as our kind of roadmap, giving a sense of where we're coming from, where we are, and where we're going. Several are very common in the field. One is the quality improvement framework, which outlines 14 key steps over 4 phases that constitute the implementation process. Some things to note about the QIF. It assumes you've chosen your evidence-based practice. Phases 1 and 2 cover the pre-implementation phase. Phase 3 covers the ongoing implementation phase. And phase 4 is meant to cover sustainment. But the only step they outline in the QIF for the sustainment phase is something called learning from experience. EPIS, or the Exploration, Preparation, Implementation, and Sustainment Framework, is an increasingly popular and dominant framework that reconsiders the process of implementation and divides it into 4 phases, the ones that are in its name. It makes explicit, I think this is one of its strongest features, the contextual factors that are thought to affect implementation at each phase. And most uniquely, it identifies the bridging factors between the levels of context. So how things at an organizational level influence things at the individual provider level, for example. And so, yeah, it's a commonly used framework and very strong. The last one I'll talk about here is the stages of implementation completion, which is a proprietary tool developed by Lisa Saldana and colleagues, which is used to empirically plan, track, and document implementation activities, again, across phases, and can be used to measure implementation fidelity. It's got 8 phases instead of 4. And one thing I really like about this one is that it's directly linked to tools for costing, implementation process, and mapping those costs directly to phases. So you can disaggregate the cost of your implementation across steps in the process, which is unique. Okay, so summary. Process models are about mapping out implementation activities, thinking about the resources that you need to complete those activities, and in theory, ensuring that your implementation plan is feasible and purposeful. All right, so now I'll dive more deep into context, the contextual determinants theories. Context, of course, is critical. Context is almost everything, right? It's a lot of things. It's why we've some have referred to it as anything that can be described as not the intervention or the outcome. Context is broad. It changes all the time. It's interactive. It's complex. It's multi-level. It changes over time. Some parts of it change over time, and some parts don't. Right? Some aspects of context are fixed. We care about context because it directly influences implementation. And understanding context can directly help us improve our implementation efforts and increase the generalizability of our research. That's really the critical piece to this use of theory, right? And what helps distinguish it from more traditional, quality improvement work, for example, is our use of theory is meant to help generalize from one setting to another. And we use these contextual models retrospectively or prospectively. Retrospectively to understand what went wrong or right, prospectively to inform the use of novel implementation strategies. So perhaps the most well-known and commonly used theory in all of implementation science is the Consolidated Framework for Implementation Research. It's a classic example of a determinants theory. It's meta-theoretical, so actually within domains, it's pulling together individual ideas from a diverse range of theories, pulling them together across different levels of analysis. So these 5 domains, from the patient and provider levels through the levels of the health system and the surrounding environment. It's designed to support systematic assessment of the factors that most likely influence implementation effectiveness, and again, to improve replicability and comparability of your studies. Initially, there were like 39 constructs in 5 domains, and as of about a year and a half ago, there's a second version of the CFAR out, which now has more than 50 constructs. It's been revised with feedback from people who've used it in the field and community members. And it can be used in many different ways. It can be used all the way from hypothesis generation through to study design, data collection, analysis, and interpretation of data. In fact, that interpretation of data stage is where CFAR and other theories like this have actually been most commonly used, because people aren't using them to design their studies, but they're using them to sort of frame their analysis and their results at the end. And I'm going to talk in a little bit about how you can use the CFAR to guide your choice of implementation strategies. So here are just some of the constructs. I think this is from the old CFAR 1.0, but you can see how the kinds of constructs that are thought to influence implementation are nested within individual levels of analysis, or what they call the domains. I'm not going to go through this in too much detail, but it's okay. How might you actually use CFAR if you wanted to operationalize it in your study? The first thing you would do, you'd identify your critical service delivery gap. What do we know works, but people are not putting into practice? So with the buprenorphine example, it might be that primary care providers in your health system are not routinely screening people for substance use problems. The next step, generate a hypothesis related to contextual determinants. So what are the possible barriers to putting this thing, let's say substance use screening, into practice? You might hypothesize that providers know how to screen patients, but clinic leadership are not prioritizing that use of their time. So from there, you identify relevant target domains and constructs from within something like the CFAR. The CFAR is too big to be completely assessed in any individual efficient study. So given our hypothesis, we might guess that a relevant level of analysis would be at the facility level or the inner setting, and a relevant construct might be implementation climate. So finally, you design your assessment. This could be qualitative, could be quantitative, it could be both. It depends much on the kinds of constructs that you pick and whether there are good measures that exist. You can introduce structural variation into your study by stratifying your recruitment on the outcome of interest. So you might find providers who are really great screeners of substance use issues, and then find providers who don't do that and compare them and sort of match them. You then analyze your data and you look to see whether the construct of interest, let's say implementation climate, explains any of the variation that you're seeing. There are lots of different ways to measure CFAR constructs. We might want to measure readiness for implementation, for example, which is a construct at the level of the inner setting or within the health facility or the implementing organization. And readiness refers to the tangible or immediate indicators of an organization's commitment to implementing an intervention. Christian, how am I doing for time, by the way? Am I sort of 20 minutes in?
You're doing just fine, yeah.
Okay. The evaluative piece, I'm going to kind of skip over because I think you've probably all heard a lot about implementation outcomes, but I'll just go briefly through it. So for measuring these constructs, we might use qualitative approaches like interviews or focus groups. And I'll note that the CFAR authors have created a website that actually offers some individual questions you can ask that target most of their constructs. There are some constructs that have quantitative measures that exist. So for example, for readiness, you might use the ORIC, Organizational Readiness for Implementing Change measure. You could also use the so-called CFAR inner setting measures. And I think I've put citations for both of those here. And when there aren't good quantitative measures available, there are the interviews or focus groups. Okay, so another example, Green and colleagues have given us an example here of how to use the CFAR to structure a qualitative assessment of the contextual determinants to the adoption by providers of buprenorphine. They use key informant interviews. They did it over time with providers and administrators, and they looked to see what kinds of how the barriers to implementation changed over time and how they influenced implementation in terms of the adoption of buprenorphine over time. I won't spend too much time here, but I think this is just a neat example, a discrete example of the use of CFAR. Okay, briefly, how to choose implementation strategies based on your use of theory to identify contextual determinants. I think I probably don't need to spend time here. The difference between the clinical intervention, the evidence-based practice, and the implementation strategy is the difference between the thing that you want to see in practice and then the stuff you're doing to put that thing into practice, right? So training, supervision, facilitation, coaching, incentives, disincentives. Another theory, model, or framework that's really important in our field is the ERIC, which is a taxonomy of implementation strategies developed by Dr. Byron Powell and colleagues at Washington University through a participatory process where they've landed at 73 things that they call these discrete implementation strategies. That taxonomy has since been adapted and expanded for use in other areas, but it provides a useful kind of shopping list of things you can consider for your strategy bundle. And they also have provided a specification on how we're supposed to report our implementation strategies to ensure that our science is comparable. Things like, who is delivering a strategy, what are they doing, who are they doing it to, when, what outcomes are they targeting, and what's the justification. And so here you can see an example of how in modern, I think commonly now in implementation research, you'll see these strategies kind of specified. This is an example of an educational outreach visit. So you'll see, different kinds of actors doing different actions to different people, all of which together constitute an ERIC strategy called educational outreach. So how do you choose strategies to test? The aim is to use your understanding of the contextual determinants to make this decision. So you use theory as your foundation. You link from what you know about context to the most promising implementation strategies. There are several tools to do this, including one that goes directly from the CFAR to ERIC. You choose CFAR constructs that you think are important or key barriers, and it tells you which strategies it thinks might be good fit. But I think the majority of the field says use participatory methods, bring together key stakeholders across the implementation process and choose these strategies together based on the data you have. And so those are some of the options up on the left here. Chang and colleagues did this. They based on their background data, the contextual determinants data, they chose intentionally a strategy bundle that they would test later on. Okay. So 3 minutes to 6 o'clock your time. How much more do you want from me? A couple more minutes or?
Yeah, you can finish 5 minutes.
3, yep, perfect. Okay, so the last use of implementation theory evaluation, given that implementation strategies are often chosen to target specific contextual determinants, and you can actually measure changes in the contextual determinants as a result of the strategies, right? So this would be like doing your contextual assessment twice to see what effect the strategies have. This is less common, but it has been done. Here's an example by Cannon and colleagues showing changes to contextual characteristics in the setting as a result of use of a getting to outcome strategy. But it's much more common to measure the distal effects of these strategies on either implementation outcomes, service delivery outcomes, or patient health outcomes. And of course, you'll be most familiar with the patient health outcomes. These are the things we most often care about, including physical function, HIV, viral load, and other things. Implementation research, we really focus on this first set, as has been defined in the core taxonomy of the implementation outcomes framework by Enola Proctor and colleagues. I like to spend a lot of time on this slide. I won't go through it in detail, but it provides a nice kind of summary, I think, of what these outcomes really mean and how they work. It's the difference between perceptions of how the implementation process is going, like acceptability, appropriateness, and feasibility, or what we call the latent implementation outcomes, and the manifest implementation outcomes, the things you can measure directly, like cost, fidelity, are people delivering things according to standard practice? And then the last thing I'll say is that a very common evaluative framework that I won't spend too much time on here is REAIM, which gives you, again, dimensions of outcomes to measure in a comprehensive population health impact assessment of the thing you're doing. And the key argument that REAIM is making here is that the individual health effectiveness of the intervention you're delivering is only one component of really achieving population health change. and that you need to measure these other dimensions, including who is the thing reaching, who's delivering it, how well is it being done, and how well is it being done over time, in order to say anything about the true population health effectiveness. And so this is just saying, like, let's say buprenorphine's perfectly effective. If not enough people are delivering it and uptaking it and receiving it, then the benefit is substantially minimized. And here is an example of the use of RE-AIM, in case anyone's interested in seeing its relevance in the substance use literature. Okay, I'm sorry that I moved too quickly through that. I should have cut down these slides a little bit more, but I really just want to summarize the idea that implementation research is about understanding implementation success, targeting issues and barriers to implementation with discrete strategies, and then measuring the effect of those actions. And we use theory, we use these kind of models, these taxonomies, and these frameworks at each step integrated, but they're all just tools from a shopping list that we use to help our science be more useful, to be more comparable, generalizable, and yeah. They can feel overwhelming and they can feel complex, but I promise if you try these out, they do seem to integrate well and support the rigor and replicability of your work. All right, thank you very much. And apologies if I went over time.
Not at all. Thank you so much, Christopher, for that level of detail. I think it was helpful to see just how the tools are not operating in isolation, but really build on each other in, identifying or assessing at each point in this process, provides the context for how we can assess the effect of actual interventions in community or in implementation. What works, what doesn't work. For me, I know, because like I said, I'm not a researcher, I'm the community co-chair. I think I just need to practice how to use these tools, because looking at them on slides, it is very complex, right? But I so appreciated how you were able to break down just you're breaking down, it didn't seem as complex as I usually think they are, because now I understand like how each of these tools could be used at different phases, but how they all speak to each other. But I'd want to open it up for questions from our participants to help us think through even further any processes, models, frameworks that you might have additional questions on. And I saw Paul came on camera, but I don't know if Paul has any
I'm here.
questions.
No, I'm here. I'm just holding back. I'm waiting. It was great, and it stimulated a few thoughts. But before I go into that, I'll hold back if other people have comments.
Mm-hmm.
Well, I'll just quickly jump ahead of Paul and say, I thought that was a lovely explanation. I mean, it is overwhelming, but actually you did a really lovely job of making it less overwhelming. And I guess maybe one quick question is how you might suggest someone who's doing the shopping that you're talking about, how they might start to think about as they pick and choose and put together what, some tools that they think will be helpful, how they might select one from another, which I guess is, maybe it's just looking at each one of them, but I feel like we often have like, can you just tell me what,
Yeah.
which one should I
What
use?
to do.
And so I just wondered if you had advice. This is such a nice way of laying it out, but sort of that next step.
Yeah, so the advice I would have is, and I offer this to students who are writing, dissertation proposals and things. I see a lot of students come through who write a dissertation proposal, for example, where they include, a full CFAR assessment, all these some 50 constructs, and then they have RE-AIM as their evaluative component. And they say, I'm going to measure all of these outcomes, across these different dimensions. And my advice is always the same. It's just like simplify where you can, don't jump straight to these overly complex frameworks just because you see them used commonly, and there are not because there aren't strong arguments to using them, but because I think you often will do yourself a disservice by spreading your study too thin and developing poor measurement plans across too diverse a range of things that you're trying to measure, right? The other advice I'd say is, as a student, what I always did was found examples of work that sort of answered comparable questions, and I saw the tools that they used, right? And then I would just kind of follow in that. Instead, the many folks are putting out really useful supportive tools for applying these things, and I can follow up with an email with some links. There are websites that help you choose. There are websites that provide data collection tools and analytic tools. CFAR has interview and focus group questions. It has a code book that you can use. I mean, so the people are trying to make this stuff digestible, but I just say break off little chunks where you can, and really use them where instinctively you feel like this fits with my research question, and don't let it blow everything out of the water for you. That makes sense.
Thanks. No, it makes a lot of sense. Thank you. And I think we would love that email if you didn't mind. That would be great. Thank you.
I see Omar's hand and then Paul's.
Hello, this is Omar Suet from Pan American Health Organization. I work with the country mostly providing technical advice for HIV care in the Pan American Health Organization. I think implementation research should be something that every government, national public program should be as part of the work that they do. But there's a lot of lack of education about that, lack of information, and a lot of confusion. My specific question is how to streamline this in order that the ethical review boards facilitate this, because many times, usually the implementation research has component that is qualitative research and coupled with quantitative research, and many times I am requested to split the protocol in 2 different protocols and provide different informed consent, etc. So what is your thought about that? We should try to push for consider these surveillance activities and no research with humans, or we should try to educate those IRBs in order to try to have the approval for everything together. Over.
Thank you. You're asking, there's a couple interesting questions in there. There's like this issue of the distinction between like the capital IS implementation science, which is this body that's really trying to create generalizable knowledge around the complex process of implementation to inform, practice everywhere, right? And to say like, how can we facilitate better implementation of health services broadly, with practical implementation research, which is more saying, how can I use these tools in my setting, in my health facility, or in my national health system to facilitate implementation within my setting? And that has implications for the IRB stuff that you're talking about, right? I think IRBs can help by, as you're saying, often you can make the argument that the research you're doing is low or minimal risk, and actually in the US, we would say like category 2 exempt, right? You're not often taking identifiable information from providers, for example, when you're doing this kind of work. And that's how I've seen it handled at some institutions, and I've seen others that have really treated this like basic human subjects research and have made you go through all the rigor. But I will say, if you're doing practical implementation work, which is bordering on the operations research and quality improvement work, anything in your power to avoid being under the regulatory environment of a formal IRB will help you, right? And that maybe less use of these tools so that you're focused less on generalizable knowledge creation as opposed to practical knowledge creation for your setting, which I think in the US at least is a key distinction for what constitutes human subjects research. I hope that was useful somehow.
I see Omar nodding, so I think it was useful.
Thank you. Sorry, it was my mind was.
Paul?
Yeah, thank you. I will, I've got a couple of things to ask or to make a point about. I will try to be concise because I am also so anxious and looking forward to hearing Julie. So one of the things I'm going to do is just a riffing on what Abby's comments and Wendy's comments were. I'm not going to go into it, but saying that with all the theories, and then there's 73 strategies, and there's this and there's that yes, and it's all needed and necessary and important. And but I'm going to make a prediction and a hope that we're on a journey and that it's going to be a coming together so that it is usable and practical, and decisions down the road are going to be within the realm of community, within the realm of healthcare systems, et cetera. So I think you're on to something important there with that. One of the points that I wanted to ask about is that, you really made an emphasis about context. And of course, that's incredibly important. You did have one slide that talked about a time one, time two, but I want to just touch on, are you looking at context and the rate of change? Because we are in a reality where rate of change can be unpredictable, it can be predictable. Rate of change at times can be measurable, sometimes it's only predictive. And that can have a huge impact on what you choose and how you do it, and whether or not you already missed the boat because the rate of change you've left the target. And one of the things you talked about, the adoption of buprenorphine, and you can say, well, let's talk about xylazine, right? I mean, let's go. And so the rate of change is also, I think, an important thing. And I think we have to think about that too. NIMH and others at NIH, and pioneered by some of the folk who are right here, are trying to make advances in hybrid research designs, right? So you have intervention and implementation embedded in the same design and at the same time, basically, in a strategic way. And I think that whole rate of change element is going to be important. And then I think the last thing I'm going to ask you, this is the thing I'm going to ask you, is about new dynamics. First, as barriers that are entering into your thinking and approach, and what CFARs and all the rest of us need to think about. New dynamics as barriers, I'm going to say disinformation and malinformation dynamics, and what that means for implementation science, number one. And new dynamics as opportunities, and what talk these days or meeting can get past somebody saying artificial intelligence or generative machine learning, and whether or not there's tools coming on board and approaches that actually is going to change the face of implementation and implementation science. Is that enough? Sorry.
That was plenty. I don't want to leave. I want to leave plenty of time for Dr. Pulerwitz's talk. I will say in the chat, I'm going to put a link to a paper that was Dr. Bidas and colleagues wrote last year before last, pre-mortem on implementation science, basically talking about some of the things you're talking about, Dr. Geist, about is the science going to science itself to death, essentially, with too much theories, models, and frameworks before demonstrating utility. So I'd let them speak for me here and trying to maybe argue that there's some hope that the field can be nimble enough. I think your point about dynamics and the rate of change is very important. Contextual assessment takes way too long, and by the time you're done assessing context, it's already changed. So I want to leave it at that and just make sure and honor the time for Dr. Pulerwitz's talk.
Thank you so much.
Thanks for that, Christopher, and for all your questions. I hope you are all thinking of rich questions that you're going to ask at the end as well. And Christopher, maybe you could process and answer some of those at the end of Dr. Pulerwitz's presentation. But thanks, everyone. And Julie, I will turn it over to you.
So thank you very much. And Chris, thank you, Dr. Kemp. Thanks so much for a great presentation. I actually have a couple questions for you too, and we'll hold to the end for that. So let me share my screen and hope that this goes well. Do you see my screen?
Yes.
Yes.
Okay, now let's put it into presentation mode. And now I have to move all these little boxes so I can actually see my slides. Okay. Hello, folks. It's really great to see you, and I'm really glad to be here for this presentation. And I was asked to talk about, as a DC CFAR researcher to share some ongoing work with a study that I'm involved with under the DC CFAR, and I will be doing that today. Happy to do that. I had hoped to present with my community-based partner in Cody Henry from Us Helping Us, and he unfortunately had an emergency, so he's unable to join us today, which means I'm going to have to be representing the team, but I will do my best. And I also have a colleague, Ann Goddard, on the call, who hopefully will be available to answer questions too, if you have questions for us. So we are going to be looking at we're focused under the umbrella of implementation science in the adaptation. So sort of the adaptation and piloting. So adapting from one context to another context. And we're going to be looking at a stigma reduction and mental health promotion program for Black, gay, and other sexual minority men in Washington, DC. So we come to this work understanding that we have a disproportionate burden and incidence amongst Black sexual minority men. That's the term I'm going to be using, SMM, in the Washington, DC area for many years, including today. And that evidence suggests that stigma and different ways that one looks at stigma, so intersectional stigma, internalized stigma, perceived stigma, there's all different ways of looking and discussing stigma, which we'll talk about a little bit, is a major driver of the HIV epidemic for many groups, particularly amongst marginalized groups, including Black sexual and minority men. We also saw, based on our experience, where we're going to be talking about adapting a program from another context, in this case, based on some of the global work that my colleagues and I were involved with in Nigeria. So adapting a global project here in Washington, DC, that there in fact were few evidence-based interventions that were addressing these particular challenges. So stigma among sexual and gender minorities. And so we developed that in Nigeria and tested it and evaluated it with a relatively small randomized controlled trial, which I'll mention a little bit more about later, and then are now bringing some of these lessons from the global South here to Washington, DC, and thinking about how we might adapt and how it might be relevant for the community here. And so this is kind of with my hat as the global co-chair of the Global Scientific Interest Group, the Global SIG for the DC CFAR, where we're thinking about lessons from the Global South here domestically as well as vice versa. And so this is an example of bringing some experiences and lessons from low and middle income countries. It happens to be that the frame that we use and the kind of work that we were doing uses this positive framing more around HIV wellness. So thinking about mental health and other issues and addressing HIV. So it's more of a contextual approach, which was very much in line with the priorities in the DC ends HIV framework. So when you think about the fifth pillar of engage, for example, it's engaging the community and thinking about this social and structural drivers of HIV, like stigma, and thinking about how to frame it in a wellness context. So it was a very good fit, and we're thinking about adapting it here. So we had two main objectives of the study that's currently ongoing underneath the EHE supplements. The first is to adapt this group-based stigma reduction in HIV wellness curriculum. And we used strategies drawing from cognitive behavioral therapy for Black sexual and minority men in Washington, DC. And we went about doing that using mostly qualitative research, so in-depth interviews with different stakeholders, including providers and DC Health, and focus group discussions with end users, in particular from the community, and then adapting and developing a prototype using a particular framework, implementation science framework called the ADAPT, ITT, or adaptive framework. And then we're going to go ahead and pilot this program amongst the community with a baseline and 3-month follow-up, and also triangulating that with some qualitative information. And so the goal here is to assess the acceptability, feasibility, and appropriateness, in particular, different measures that Dr. Kemp already mentioned earlier in his great overview presentation, and also including looking at the potential for stigma reduction and supporting HIV wellness of the intervention. So sort of seeing that under appropriateness as a kind of umbrella where we're thinking about what also can be thought of as some preliminary efficacy. Here's a slide with our team, the partnership. I am DeMark Hickson is the executive director at Us Helping Us. And Us Helping Us is a full-fledged member of the DC CFAR. He is a co-PI with myself. I'm based at the Population Council, an organization that focuses on applied research to inform programs and policies. And so it's a really nice fit with the implementation science lens. And I'm also part-time at George Washington University, where I teach that class, for example, that was mentioned earlier. And then other members of our team, including our study coordinator Cody, who we had hoped to co-present with me, and who I hope will be on the call for later on, from the Population Council, Jennifer Quate from the Whitman Walker Institute, who's providing huge support as well, and thinking about how we might next steps and scale up, as well as Ade Ogubaju from Us Helping Us and Arona Jang from Population Council. So I was asked to show a couple of the models and frameworks that we used. So what I'm sharing here is, in fact, the sort of the implementation research logic model that was asked of all the teams when they submitted the proposal for the supplement. So they all submitted this logic model, which lays out many of kind of the determinants of what we understand to be going on, where we look at these process, characteristics of individuals, outer setting, inner setting, and intervention characteristics. So pulling some of what Dr. Kemp was talking about earlier. And then we look at the implementation strategies, mechanisms, and intervention, and then finally the outcomes we're looking at. So just to point out a couple of determinants of what, and I find this really useful to have that logic frame like this, where you kind of put it all in one place and combine it. What do you think is driving what's going on, and intentionally separating out between intervention characteristics, for example. So it's based on one that is documented previously, but we're not quite sure about how well you can adapt from the Nigerian context. So those are some of the intervention characteristics, for example. An inner setting, in this case, Us Helping Us is the inner setting. They're the organization who's going to be facilitating and implementing the pilot, and is the site where we're also adapting it and speaking with different members of the community. The outer setting of what's going on contextually, stigma and discrimination driving quite a bit in terms of incidents, in terms of acquiring HIV, but also whether people are accessing services and care. And then characteristics of individuals. So we're looking at various elements, and particularly looking at internalized stigma here, as well as other mental health outcomes and resilience in the face of stigma. So we have all these intervention boxes in the middle, which I'll go into a little bit more in a moment, and then those outcomes that I mentioned, the feasibility, acceptability, and appropriateness, but we're also looking at directly at stigma, internalized stigma, intersectional stigma, mental health, and the potential increase in current service use. So this slide is a pretty busy slide, but it shares a summary of the original curricula that was developed and tested by the Population Council. And I just want to tell you a little bit about that background. So the Population Council has an office in Nigeria, and we have been working to offer services, particularly HIV and related services, to sexual and gender minorities for many years in the Nigerian setting. And in this context, we focus a lot on creating, stigma-free environments where folks can access services, provider trainings, etc. And there was a call from the community to say that they really wanted some psychosocial support in addressing issues of internalized stigma, where folks are internalizing stigmatizing views, basically, that they're exposed to everywhere when they're outside. from family, from community, as well as discrimination. It's institutionalized discrimination in that there are laws against same-sex behavior, etc. So with this call from the community, we then went about to say, okay, let's develop some services related programming. And we found that there was really very little in terms of evidence-based interventions to address internalized intersectional stigma experienced by sexual and gender minorities anywhere, really, but certainly in the African setting. And so we developed this program and then tested it, found some very positive results, some promising results, I guess I would say, regarding psychosocial outcomes, regarding an increase in PrEP use, et cetera. And then we had this opportunity to think about how to bring some of those lessons here. So this is the summary of what's in the curricula in Nigeria. It was based in Nigeria. And it had 4 sessions. And it on the right, if we look on the right-hand side, I'll just point out a couple of points. One, it was to promote critical reflection around multiple stigmas and how they relate to being, I'm going to put my boxes so I can actually see what's here. Critical reflection around multiple stigmas, understanding how they can be internalized. And then secondly, learning and practicing some cognitive behavioral therapy skills, more individual coping skills. And then thinking about positive coping skills related on the 3rd session, physical, social, and mental health, as well as self-care. So we framed HIV prevention and treatment in the context of self-care. And then lastly, in a 4th session, thinking about developing networks and getting the help we need. So identifying ways to build a supportive network and to promote shared resilience. Oops. So we used, when we're thinking about adapting it here in the Washington, DC setting, something called Adapt It, which is a framework for an adaptation process. And there are various steps, as you can see here, ranging from assessing the context all the way through producing the adapted curriculum and then training and testing. So you can see how that kind of maps onto phase 1 and phase 2. What I'd like to do is share with you kind of how we are doing the steps in phase 1, which are ongoing. So here, these are our phase 1 adaptation steps. And you can kind of see how the team is working, the partnership is working together at every step along the way. So the full team took the original curriculum and reviewed it together. So it happens to be that the team includes, us helping out with a lot of experience working with the community in various and facilitating HIV-related programming, for example. Anne and I had developed the curricula in Nigeria, so we were able to kind of think about how we might want to adapt it even before we created this draft 1 that we discussed with the community. So that took a number of back and forth, and there were several themes that we already knew that we wanted to change or enhance, which I'll talk about in a minute. Then we went to conduct a series of focus group discussions with end users, with Black sexual and minority men, and in-depth interviews is what we're in the middle of right now. So we literally just conducted these focus group discussions over the last couple of weeks, and we quickly looked through themes and wrote up the summaries afterwards so that we could share a couple of emerging results with you, which I'll get to in just a moment. But what I want to highlight here about what we're learning a little bit from the implementation science process is we spent some time thinking about how do you best get feedback through talking with the community to inform the intervention. So we originally planned on a series of individual focus group discussions, for example. And we realized that just talking to people once, we wouldn't be able to go through a 4-session curriculum. How will we get, and the sessions build on each other, and how could we get a good feedback that way? So we ended up sending an amendment to the IRB where we created essentially a cohort, so a series of focus group discussions with the same people, kind of a working group where we were able to talk about reactions to different exercises with different sessions along the way. And then with that perspective of the whole program, what is your reaction? Sort of how acceptable, how feasible, how appropriate would this be? Including, and we also got advice on specific exercises and elements of the program along the way. So that we found that shift to be very useful. And now we're about to go, those themes that came out of the focus groups are helping inform the follow-on in-depth interviews with community members and other local stakeholders so that we can go even more depth there And we're also taking the opportunity when we're talking to people to add a small little survey of the acceptability, appropriateness, feasibility using these measures that I think Chris might have mentioned earlier. So the next step after all of that is to create a draft 2 and to also talk with different topical experts. So we've talked with CBT experts, for example, to get feedback on, is this really a CBT intervention? Is it, the strategies, how much do you need to include? That sort of input. And then folks who have a lot of experience with stigma programs in the US. And so we'll be developing a draft 3, and that's what we're going to be piloting. So we knew ahead of time there were several key themes that we wanted to explore during phase 1. One theme, for example, in addition to kind of walking through all the different curricula components, was how do you balance sort of a necessary reflection and skill building around stigma, including internalized stigma. These are difficult issues to talk about, with positively affirming everyone's identity. So it's intended to be a group session where we're really positively affirming people's identities. How do you balance that? Also, we wanted to explore issues related to this being an HIV status neutral program. So we designed this so that people who may be living with HIV and people who are not would come together as a group to go through the curriculum. And how well will that work here in DC? Thirdly, we really wanted to enhance some of the shared resiliency thinking. Sort of how do we use sort of advocacy strategies to create sort of a sense of shared resiliency and a response to stigma that people may experience, as opposed to only coping mechanisms that people were developing. And then lastly, because this was a program in Nigeria, we intentionally wanted to add a lens related to structural racism and stigma related to race here in the US. Helping us was super helpful with the recruitment process. They have a very structured, excellent recruitment process. They led that when we established a set of eligibility criteria. We wanted to talk to a range of participants or participants with a range of characteristics, by age, by where they lived in DC, by HIV status. And so we were able to draw upon this existing network at Helping Us. And as part of that process, we were able to talk to folks about if they weren't able to commit the time or weren't interested in this series of focus group discussions, maybe you consider it a follow-on in-depth interview. So that's also how we're going to be doing that. I have just a few slides on the initial results here. Let me see what we're doing. Hopefully we're doing okay, Christian. Yeah, we have like 3 more slides. This one, just initial feedback, the structure that we had, the feedback seemed to be, it was going well with the 4 sessions, 2.5 hours. It was important to give options for timing, such as weekends versus weekdays. We intentionally had facilitators that were based in the community as opposed to only psychologists, psychiatrists, and folks reaffirmed that kind of having more of a community health worker facilitation, which is what we did in Nigeria, resonated well for folks. They recommended against grouping by specific ages of where people live. They preferred in-person to virtual, and they preferred having combined groups, as I was talking about the status neutral program, as opposed to having separate groups for people living with HIV. Here are just a couple reflections from the participants that came out that I wanted to share, where those discussions went well, to say, and the feedback overall was that this provided a rare opportunity to discuss life challenges. So these themes were not talked about very often, and there was an opportunity to do so. They felt it did build skills to address internalized stigma. It provided a space for mutual support. It also improved awareness about linkages to services, which was important. And feedback was that it was important to frame HIV as self-care and to make folks aware of services, but within the context of wellness, and to not overemphasize the HIV services. So this program was not about HIV services. This program was about mental health, stigma reduction, wellness writ large. When we asked them did they think that this program would in fact reduce stigma, we had one participant say 100%. So that was Great to hear. And another talk about that, just being part of the focus group discussions, reflecting on these issues and giving advice helped positively influence their own views, and they were practicing the tools. So a couple of takeaways about program adaptation from my and our perspective, that it's a multi-step process that incorporates local epidemiology, context, and multiple perspectives, that is very useful to draw upon one or more frameworks to systematically take into account some of the issues we talked about, like the logic model or adapted model, that most often these adaptation and pilot testing studies will focus on acceptability, feasibility, and appropriateness, but they can also examine some what we might call preliminary effects, so that you can be thinking about preparing for a larger evaluation. And then lastly, I would highlight that having a community partnered model, both to implement the study and to speak with community members to help inform and improve the intervention that we're going to be testing, is key for many reasons. But and here is just one of them. My last slide is a quote from the focus group participants, where this individual said, "I don't know how frequent these focus groups are in the making or the birthing of these interventions. But I think this is very necessary because you get an idea of who you're trying to reach, who you're trying to get in touch with, what's acceptable, what's not. Because a lot of times people just throw programs on us and they wonder why we don't show up. And I think this is preventing that from happening because we feel included. And because we feel included, we can promote it." So I will leave us there and stop sharing. Thank you very much.
Thanks so much, Julie. Great presentation. It seems like, well, it's clear you are still in the process of your adaptation research, so or implementation science study. So we appreciate you for sharing, especially these preliminary findings almost. You know, as I was looking through looking at your presentation, I'm thinking back to when we were doing healthy relationships and SISTA, right? Which was CDC effective interventions for HIV. And I'm wondering, because as a CBO, we don't have the capacity to have a 6-7 person research team to help us with adaptation of that intervention. And at the time, we were told, you can only make these adaptations. If you make these adaptations, but stick within the rest of the frame, this is going to work, right? But we really don't know if that worked. But in the absence of having a 7-person research team, what can CBOs or health departments take away from this type of process that helps to think through, how do we know whether what we're implementing works for the population we are working with? Like, what aspects of that process could be simplified for community-based organizations implementing or adapting interventions in community? I don't know if that.
Yeah,
makes
yes,
sense.
it does. Yes, yes, it did. So a couple thoughts. Kind of coming back to a point that Dr. Kemp made. So how to simplify. There are all these. So if you look at the adapted, I didn't go through all those steps because there are a lot of steps. And we were talking earlier about a framework that has like 50 different domains. So you want to do something that is useful for you, that's feasible for you. So if you want something to, I do think that if you're taking an intervention for one population or one setting and trying to move it to another, it's a good idea to check that the community you're working in and working with will find it acceptable, feasible, etc. So there are ways of doing that. That certainly, you know, because these focus groups, for example, were led by Cody from Helping Us and Anne, who's on the call. And you could be asking those questions. It doesn't have to be necessarily part of a study, even with, et cetera, consent forms, et cetera. You could think about that. But I think you can't assume that a program that's over here will not necessarily going to work over there. And that's the same thing for some of the tools and the measures we're using for stigma, for example. So you want to be able to do that. And the question is, how can you do that without it necessarily taking up, all of your time? So and so that's one piece. The other piece is, I think we're talking about fidelity. You mentioned something about fidelity. And that's really key, that if ideally you're taking evidence-based programming, that implementation science is about taking evidence-based programming, something that we know works in at least one setting, often in many settings, with many populations, that you feel more confident with, therefore will work in this other setting than something that hasn't been tested. But you have to think about how to implement it in a new place. Ideally, you have the developers, or you have consensus of what is kind of the essence of that intervention that you were talking about, SISTA, for example, the essence of the intervention that you want to make sure you implement, but the other aspects are to be flexible about. I had a similar experience with Stepping Stones, which is a very commonly used program around HIV, where, communication, relationship building, HIV prevention globally. I mean, it was developed in Uganda. It had a big test in South Africa. It's been used now in the US and many, many countries. So the developers of Stepping Stones, as well as other community-based programming, that where you're trying to shift norms and attitudes, often in group settings and community settings, came together and created this group called CUSP, I think, where they identified sort of, these are the key elements of what we're doing that you need to include. And if you don't, these are the elements, and the other issues can be quite flexible, because they were finding that people were taking the intervention and then just using it and changing it dramatically without checking that it might work in that context. So you need to find a balance between checking when you go to a new place without being so overwhelmed that you can't, you don't know where to, you have no idea what to do.
Yeah, thanks for that. And in the absence of other hands, I do see Alan unmuting. So is a lesson from implementation science that like a focus group or focus groups should be integrated pre-implementation of any evidence-based curriculum in a new setting or with a new population? Throwing that out, and I'll turn it to Alan.
Am I waiting for the question for an answer to that, or should I go?
Oh, I mean,
sure.
I don't know if you want to, I don't know what you think, Chris, but I think if you go to a new location, you should do some testing, some pre-testing somehow, whether it be instrument measures or whether it be an intervention, to know that it might work. Now, you also, it being an evidence-based intervention, EBIs that we're talking about, it has a lot of some backing already, which is good to have, because there are a number of organizations that are also developing interventions from scratch and don't really know if they're working, as you're saying. So you want to draw on something that's already out there. Dr. Kemp, would you like to comment on that?
Oh, that's perfect. Just to add that I think it's increasingly clear that the application of both community-based participatory approaches and implementation research approaches at the outset of intervention development are, relevant, right? Like we should be thinking from an implementation perspective and have adequate engagement from the community right at the outset of even developing an intervention, let alone adapting it for a new community. And if you're not doing that, then you're missing out on the key part of the process.
Thank you. Alan?
Julie, I have a simple question that I've always wanted to ask, and I've never had the opportunity, which is, when you're implementing a psychological or socio-behavioral intervention in a new population on different parts of the planet, and when you're trying to take something that worked in one place and implanting it, do you get feelings at the back of your neck as a researcher, like parts of this just don't make sense or parts of this make perfect sense? And what's your feel when you go, because obviously when you have a pill is likely to work in one place or another. People, they can move somewhere, you give them the same treatment, but so many of these interventions are so dependent on context and culture. And does it feel like it's forced at times, or does it feel natural? Perhaps I'm not asking this question intelligently, but that's what I'm
no, it makes perfect sense what you're asking, Alan. And I think it really, it depends. I mean, it's different circumstance, I think the answer is it depends, but it does take me back to the importance of community partnered work. So I think that I would not do any work without working with people in a local setting, whatever it is, from a local population. And you know, we work with universities around the world and work with community-based organizations. And this is especially true when you're doing community-based work, right? So you have sort of the face validity from people who are representing the community and experts in the field. But even in this circumstance with our adapting here, because Nigeria is different from Washington, DC, when we're working with Us Helping Us, and staff members that are helping us in many ways are representing the community. This is an organization that's founded by Black, gay, and sexual minority men. And the services are for the same population. And so they, Us Helping Us gave huge relevant input, but they also said, we're not the community. We need to make sure we're also talking to members in the community. And so we had always planned on having, talking to end users, et cetera, which we did through the focus group discussion. So I think a lot of it's about being community partnered. I do think that and it also comes back to fidelity issues. So I think there's that balance between cultural contexts. Many cultural contexts around the world, many different populations are very different, but there are some elements to programming addressing certain things that have been determined to be effective that you want to be applying and then adapting and refining in consultation with the community from the very beginning, as Chris mentioned. And is there anything you would like to add to that if you're still on? You've worked in many settings.
Hi, everybody. I would just add, I think that, you know, certainly the cultural adaptation to a particular context, to particular cultural nuances, et cetera, is important. But for example, for the program, for the curriculum, et cetera, that we were testing, a lot of those elements are commonly used elements and are common to sort of human beings, almost as if they were a pill. For example, like the experience of internalizing different stigmas. For example, the importance of being able to reframe sort of negative automatic thoughts that come in, the importance of creating, healthy social networks around.
Just FYI, we're closing in 14 minutes.
Okay, thank you. The importance of creating healthy social networks, the importance of building shared resilience, these types of things. And through the process of the focus groups, we definitely were able to further sort of enhance the acceptability, the appropriateness, et cetera. The other thing I would say is, it's even for these types of programs, we need to get away as a field from constantly reinventing new programs. We need, we know what the effective elements are to programs like this. And the more, you think about the RIE model, for example, we keep doing the efficacy, not even effectiveness, but efficacy, because we're consistently developing new programs like this. So this is adapted from several different existing curricula or existing programs. And the idea, what we're hoping is that it can be scaled up and not even just for this population, but apply also more broadly to other populations. Because again, those sort of active ingredients of the intervention are the same. And we think that the adaptation can be done in hopefully relatively simple ways, like this series of focus groups, which were, incredibly enlightening.
So just adding to that, so the mechanism of change has been kind of tested in many contexts. So things like cognitive behavioral therapy, which is really very widely used. And then, and we intentionally created to be a group setting and intentionally created to be facilitated by not just psychiatrists, so that it had potential for scale up and potential for adapting in different contexts and being able to do that in many different places, particularly where they don't have mental health professionals very widely available. So the only other point I wanted to raise was about, there's a parallel discussion about putting on my researcher hat about measurement and scales and how well can you adapt those in different contexts, such as these stigma scales that we now are going to be using to measure changes related to internalized stigma, which is something that with my other hat, I spend a lot of time doing scale development, as does Anne. So we could always talk about that another time, Alan. But I do think that that is also a relevant ongoing discussion about how well can you do that across different cultural contexts with measures for very complex social constructs like stigma, like gender. I'll stop there. Thank you.
Quick, Abby, quick reaction. Thank you to you both, because it seems I have tremendous respect for the process because it would seem it takes tremendous skill as an investigator to sort of be in the field and recognize those things like Anne was saying, which are common to all human beings across cultures, and which are the things which just clunk because, you know, things don't make sense because of local beliefs or practices, and you have to be pretty sharp to distinguish those things, and my respect for the process.
And a good listener.
Any other questions? For both Julie and Chris.
I think I had one for Chris. I'm trying to remember what it was. I wrote it down in a little. Okay, what is it? So I'm thinking about issues that come up in the class that I teach, right? And when because of the confusion, folks are talking about confusion early on and how to handle models, theories, and frameworks. So just last week, for example, let me give 2 or 3 kind of questions. One question would be, what's the difference between program evaluation and process evaluations and implementation science? Like, it's all this overlap and I have no idea how to tell it apart. Another one would be, I had a question about sort of theories as compared to models and frameworks. So sometimes we're incorporating sort of what I would call the whys, sort of the theories, and like socio-behavioral theory, and sometimes not. Sort of how do you describe that? And then the last point was about sort of research uptake. It may be a little far afield, but a key part of the definition of what it means to be successful implementation science is that people take up these findings in programs or in policy. And what kind of theories, frameworks, models do you tend to recommend to guide the research uptake process?
Those are all great questions. So starting with the sort of like distinction between program, process evaluation, implementation science, I think of these as like kind of nested dolls in some ways, right? Or just like increasingly overlapping Venn diagrams. But I think what implementation science has tried to do is to like create boundaries and say, you know, we're going to, through our use of theory, through our specific outcome taxonomy, and through our specific approaches to measurement, we're going to create we'll use the elements of program and process evaluation, operations research, ethnography, health economics, clinical epidemiology, biostatistics. I mean, it's inherently interdisciplinary, right? But we're going to apply it with this specific framing around process of implementation, and we're going to do it to generate generalizable knowledge. And that's really it. Like that's, I think you could pull apart that definition all you want and say, well, you know, yeah, you're basically just doing QI with like some bells on, right? Or like process evaluation. I think that's probably true. But if it motivates funding, if it motivates people to get excited and interested, and if like disciplinary credentials are like important in our society in some ways in order to get things done, then I guess that's enough justification from my perspective to like define the boundaries. I don't know if that makes sense.
Thank you, Dr. Kemp.
And then what was the second question around?
Yeah, let's skip that one. Let's go to what was the last, do you remember the last? Oh, research
uptake. Well, I had something good to say about the second one. What was it?
Oh, it was about theory, the difference between like socio-behavioral
theory.
So
it's funny. I always wanted that too, because I'm like, well, these aren't all theories, right? Like ERIC's not really a theory, it's a taxonomy, and so is the implementation outcomes framework. And I always get just confused about the distinction between what's a typology and a framework and a nomenclature. And anyway, I think that the reason these all get bundled together into like, when you're teaching a class, you teach a theories, models, and frameworks lecture, is because they're like the the ways that we signal we know what we're doing, right? It's all the phrases and the frameworks that you use in order to show someone I'm doing implementation science. I cite this paper, I cite this paper. And I think it is a danger, right? Because it means that the science is becoming kind of like streamlined into, you have to show your credentials by using these tools in this way, and use the right terminology to say that I'm doing implementation science. But for me, that's why they all get bundled together when you're teaching about them. The theories, the things that are obviously theories, get put into the same mix as like a typology like ERIC, because knowing how to use ERIC and CFAR both help you fit into like this category of implementation science.
Thanks.
Maybe overly cynical definition. And then the other thing about theory uptake, I don't have a great or research uptake. I don't have a great theory that I use or model that helps me like guide translation of research into practice. I think, again, coming back to the idea of community engagement, if the community and the relevant state, like participants, the people who care about the implementation process have been involved in your research from the beginning, that is probably the thing that's most likely to ensure that your research translates into practice.
Thank you.
Do others agree?
Yeah, I mean, for me, as a community-based entity that may be operating with a different population to Julie, us helping us in the research that is presently happening, I'm trying to think, once those products are created, that comes out of that project, what I would want to see is what process did you use for the adaptation, and how can I then utilize that as I think about adapting for the population that I might work with. So for me, uptake would be, are the outcomes documented in a simple enough way that, there would need to be those sorts of categories of how the research is structured for me to look at that to say, all right, as a community-based organization, here is what I would take out of this to utilize as I think about my adaptation process. So I don't know if that could be formatted into a framework or model for uptake, but I think that's a key element of that model.
Yeah, it's like you got to give people the kind of evidence that they need or want, right? I'm increasingly finding I'm arguing for inclusion of cost effectiveness and budget impact analyses in all of our work, because it's like people want to know that they can afford the thing. Outside of like knowing that it's going to work great and knowing that they like it and it looks good, simply like, can I give me an estimate of what I'm going to what's this going to do to my budget?
Thanks for that. Tammy, I see you. Oh, sorry. Go ahead, Julie.
Just one comment that some years ago, colleagues and I developed a sort of guidelines for steps to take to make it most likely that research will be taken up into programs of policy. And the first step is that the key stakeholders who can actually influence the outcome are involved in the very beginning. But there are other steps like being involved with data interpretation workshops and having people all hear what these results are and help inform how to then shift the program or what policy to address. And there are data use plans to create. So there are some strategies out there, but I haven't seen a lot about models and frameworks that are likely to promote that. So that would be interesting. I'll stop there.
Thanks for that. Tammy?
Hi, so I know we're up on 2 minutes, but I will try to be quick. Actually, I'm not sure if you know me. I work at Hopkins as well with DeMarc and Adi and everybody. And thanks for your presentation. I do have one or two comments and then maybe a question. I'm from Nigeria myself, so I'm very, familiar with Population Council. I lived 20-something years of my life in Nigeria. I'm very familiar with stigma, discrimination, and constant fear of being gay in Nigeria with the law and everything. So it's good to actually see that there's a stigma reduction intervention, that happened over there. So I was just curious to see, where that intervention is at this point. Like, is it being adopted by any organization in Nigeria at this point? Because I know Population Council has also moved from being an international space in Nigeria to something a little bit more local now. But also I'm, curious in terms of, are you looking at comparing some of the outcomes in terms of the stigma reduction, for, US based and Nigeria, because again, stigma in Nigeria is completely different from stigma here in the US, because even with some of the intervention, Nigerian gay men are constantly living in fear of persecution because of their sexual orientation and gender identity. So are you also looking at, at the end of the study here in DC, are you looking at some sort of comparison in terms of the outcomes around, stigma, since that is the context that we're looking at? And also I'm curious to see if this intervention was sustained, because I believe this is something that will be constantly needed, especially with the situation of things in Nigeria.
So really great to see you. I think we might have overlapped before at some meeting or in a box
Probably.
somewhere on a Zoom with us helping us. It's great to see you. Thanks for joining.
Sure.
Thinking about the original question that you had. So the original work was funded by the Elton John AIDS Foundation. And we had the opportunity to kind of nest developing this intervention and testing it testing it in sort of more of a study format because of that funding. Now, there is some additional funding from the Elton John AIDS Foundation that's just getting started, but the Population Council is working with the local organization. So Population Council still has an office as an INGO, and there's also a local organization that has evolved, that is was founded by exactly CFI. So CFI is still in existence, and so CFI and Population Council are going to be partnering on this. So CFI is an independent organization now offering services and collaborating with Population Council on this work. And so we're going to be adapting some of these sort of mental health stigma reduction work in this new setting, also working with pharmacists and pharmacies. It's kind of the focus has shifted more around HIV prevention than care and treatment. So there is some work ongoing, but it would be wonderful to see how we could, it has a lot of potential for scale up. And so my hope is that there'd be some interest to expand on some of this work. Coming back to the first point that there's very few interventions of this kind. Coming back to the specific circumstances in Nigeria, so as you mentioned, it's quite different in terms of the institutional stigma. There's what the laws look like and how that plays out in people's lives. I think that, and that's something we're talking about now, that the measures of whether you experience kind of internalized stigma, there may be different levels of it. But this is still something that is really cross-cutting, that is experienced by a lot of people who are living with HIV, a lot of people who are sexual and gender minorities, a lot of people who have internalized stigma is experienced due to a number of stigmatized identities and experiences, anti-LGBTQ, racism, et cetera, et cetera. So I think that stigma itself, we do see it in many, many contexts. And so the People Living with HIV Stigma Index, for example, that documents stigma experienced by people living with most widely used tool to document stigma from the perspective of people living with HIV find high levels of stigma in many, many countries, whether it's Nigeria or the United States. And so I think that this is kind of a global issue. And then there are nuances we need to take into account, including probably different intervention strategies, because one is policy that needs to be addressed, and there may be others. But I do still think that the measures, and we should expect that we're finding stigma in many places.
Sure. Thank you. Thank you.
Thanks. Thank you all. So it's 7:03 p.m. I think this was a rich discussion. I do want to remind you all that our last in the series is on the 29th. And that session, Christian helped me with I think it's strategies and outcomes is the topic for our session on the 29th. So we hope you would spread the word so we could have a further rich discussion. I do want to thank Julie and Dr. Kemp so much for your time and attention to detail with these presentations. It's been such a rich conversation. Dr. Pulerwitz, I have more questions as it relates to how, we adapt for future. Like, does every CBO have to have a partnership with a researcher institution in order to adapt in the future? But we can have that discussion in detail via email.
That sounds
But
great.
yeah, thank you all so much. Thanks for engaging, and have a wonderful rest of your evening.
It was
Thanks,
a pleasure.